Good day. I'm Dr. Charles Denham. I'm chairman of TMIT Global and one of the co-founders of the MedTech Bystander Rescue Care Program. I'll be both a speaker and your moderator today. We're so very blessed you're joining us to learn how to keep your family safe.
Jenny, thank you so much for being our voice of the patient today. Would you please open us?
Thank you, Dr. Denham. This is a really exciting day for me to hear about the results of the study. I'm looking forward to today's webinar, and I just, again, would like to thank everyone who's here for being here, and please share the website with all of your friends, families, and colleagues. I'll hand it back to you, Dr. Denham.
Thank you, Jenny. So, Jenny, would you please share the last word with our audience?
So that is the message from Jenny, and what I'll do is I'll go back to our program. We're going to toggle back and forth today because I'm remote and actually delivering this from my car. Jenny is a long-standing patient advocate. She's been our voice of the patient for the whole 24 months. She is the winner of the Pete Conrad Global Patient Safety Award, as is Dr. Greg Boats and Chief Adcox. We're going to have recorded sessions from Dr. Christopher Peabody, Charlie Denham III, my son. Heather Foster will be joining us both live and in a recorded fashion. And Dr. Brittany Barta Owens sends a message to us to keep the message going on getting vaccinations for our kids, adolescents, our young people, as well as our middle-aged and seniors. David Beschk and Charlie Denham developed a checklist for families, which we'll address as well. So our purpose, mission, and values are critical to us. Our purpose is we'll protect, that our focus is on our success, that we will protect and enrich the lives of the families and patients and caregivers. So we'll come back to our purpose, mission, and values, very important to us. We measure our success by how we protect and enrich the lives of families, patients, and caregivers. Our mission is to save money, save lives, and create value in the communities we serve. And our core values are I care: integrity, compassion, accountability, reliability, and entrepreneurship. We really seek to live those values. Do we every day? No. Do we attempt to do so? Yes, we do. Our disclosure statement is on slide 10. No one has anything that they wish to disclose. No money has been received from a pharmaceutical or a device organization of any type, directly, indirectly, or in an affiliated way. This program has been funded by Family Philanthropy. You can go to the website to see further information that'll be posted. And because this program will be longer than 90 minutes today, we're going to cover a short section and then have two longer videos for those who would wish to have a deep dive. And additional information will be posted on our website that will allow you to follow through on some of the information that we'll be adding over time. If you wish to kind of get to see our Q2 2022 progress report, we have a videotape on our website that addresses how we've tackled this variant evolution from the Alpha, Beta, Delta, and Omicron, and now we're facing Omicron lineages and subvariants, and it will allow you to kind of see the work that we've been doing. Interestingly, this is April 5th heat map from Johns Hopkins showing where the cases have been reported. Unfortunately, when we look at today's map, which we pulled off of the web this morning, you can see that now we have an uptick. And as most of you probably realize, testing is not being reported anymore because so many people are testing at home. And so we're only receiving a small fraction of the positive tests. So the best thing we can do is really watch the wastewater in the communities where we live and the presence of the virus there, admissions to hospital, and deaths. And so we've addressed this video on our master website, and you can go and watch the update. Now, Dr. Boats and Chief Adcox and I started an emerging threats community of practice before the COVID crisis to focus on the 30-some-odd issues that are emerging threats that should or are keeping our leaders up at night in our major medical centers. And a number of organizations have participated in the shaping of this with us, and you see them on this slide. And interestingly, readiness for epidemics, including preparedness for testing and volume surges, was one of the issues that we identified long before the COVID crisis. And so this was an area that most people were worried about. For those of you that have not been with us before, we are very blessed to draw on a global research test bed of over 3,100 hospitals and 3,000 communities and 500 subject matter experts. And you say, well, how the heck could that happen? How would you have such a big group? It's because we've done so much work in patient safety over the last 37 years with the Leapfrog Group, with the National Quality Forum, with 4 or 5 of the federal agencies. And we've been really blessed to have the majority of those folks that we work with stay with us. So we drew on that group to put together this community of practice. And we started with 60 subject matter experts. And you see a number of them here. You see Chief Adcox on the top row there, and a number of great experts and actually people from the community, ranging from kids from the age of 8 to 80-year-olds. And we also drew on the contributions from our Discovery Channel documentaries, Chasing Zero and Surfing the Healthcare Tsunami. And those that are in our next 2 documentaries, one is 3 Minutes and Counting, Bystanders Care, and one that Chief Adcox and I are working on very, very closely, and that is First Responders, Best Responders Out of the Danger Zone. Over the last 2 years, and I'm not going to read this slide to you, but we've really been blessed to have taken the study. We're addressing many broadcasts, produced a campus safety magazine summit, published articles, and a number of programs that we've had the blessing of working with. One was to recruit a number of students currently at our leading universities or alumni who contributed to our program for young people in high school, college, and our young adults under 30. And they come from a number of colleges, which you see on the slide before you there. And we run these webinars have been running them every first Thursday of the month. Our hope is that we won't have to run them very much longer, but it all started, and now let's talk about our study. So these are the essential critical infrastructure workers that were identified by Homeland Security as essential and critical to our nation. In August of 2020, they added educators to this group, and what we found was if you save the families, we found that the spread was actually occurring through families, and that was our hypothesis. So that's why we focused on the families of essential workers. And we believe that if you save the families, you save the worker, and it turned out to be true. We focused on what we call the 5 R's. Readiness, which is preparation and regular review of a plan for a family. Response, if someone gets infected or needs care. Rescue, if they have serious conditions. Recovery is recovering from, and now we know that long COVID is a really critical issue. And resilience, and Chief Adcox, you may want to address what target hardening is, but what resilience is to focus on making sure that you're the most resistant target to new threats. And we made this a cycle because we knew that we would be learning over time. Now, we undertook this study focusing on the 5 R's using a modified Likert scale of 10 very strongly agreed to 1 very strongly disagree. And our questions were as follows. We focused on, my family is ready to take care of a loved one with coronavirus in our home. The second, and then these are the approach that we followed. And I'm going to back up a minute. If you can see in the text in the middle part of the slide, we also had a free text entry format, so people could put in the areas that they were really interested in and what was critical to them. And this was very informative to us, as well as interviews constantly that we undertook over the 24 months. And it's much greater than 1,000 workers, but our goal was to have 1,000 workers, which we actually, and families and the general public, and we exceeded that number very easily. So these are the questions that we ask. Readiness. My family is ready to take care of a loved one with coronavirus in our home. We ask the second question, my family knows what actions to take if a loved one becomes infected with coronavirus, and as the evolution of quarantine and isolation occurred, we addressed it. Rescue, my family knows what to do when someone develops severe COVID symptoms, and those evolved, as we saw with the CDC. Recovery. My family has a safety plan to return to work and play when the corona social restrictions are relaxed. And then resilience. My family has a plan to make them less vulnerable to epidemics in the future. Now, we can't betray the data today because we're actually publishing these articles, and we, as you all probably know, the journals won't accept articles if we pre-release the data. But let me kind of tell you what we learned. And Chief Adcox is a co-author of this paper that was published in Campus Safety Magazine. We addressed the fact that the problem was family transmission chains, the solution were family coronavirus family safety plans, and that the plans must be flexible using impact scenarios so we kind of know what to do if. We use the 4A checklist framework: awareness, accountability, ability, and action. And we use the 5R scorecards of readiness, response, rescue, recovery, and resilience. And we will have this article posted for you so you can download it. The 3 whys were: why have a safety plan, why now, and why this. And our message was targeting educators, students, and law enforcement leaders. On the right, you see back then the family impact scenarios, which now we're updating in the final article because things have changed. And now we have testing and 2 different types of testing, or more than that number of tests. But when we developed this, we developed a grid of what to do with each of the R's, which are the columns, and each of the scenarios, which are the rows. And this message really has been very, very well received. And now we know, as we head into our 25th and 26th month of dealing with the coronavirus, that the scenarios have changed, and our final paper will address how things evolved. I had the delight and wonderful opportunity of learning from Professor James Reason directly, who told me, and so many of us have quoted his Swiss cheese model of defenses, and how our defenses are like holes in Swiss cheese, and we have to have many layers. And so we animated what he described, and he actually described that it was actually a graduate student that hypothesized this. He's been the one to really pioneer people promoting this, and many people attribute it to him. And he's so humble to say that it was definitely a graduate student. But social distancing is a layer. It lets virus through. Masks are a layer we add to distancing. Disinfecting high contact surfaces, at first we thought were really important. They're far less important, but nonetheless still important. Ventilation became very important late in the pandemic because of the aerosol spread, and testing became a way for us to be able to dramatically reduce risk. And so if you had to leave today and we said, well, what did we learn in the 1,000 family study, and I'll go back to Bill Adcox in just a moment, we learned that these are just like what they practice in security and in law enforcement, that you must have layers of protection, and no one thing is going to solve the problem. So when we looked at one of our webinars, we addressed our stressed emergency safety net, comprised of bystander rescue care, which now we have to be a lot better equipped. EMS takes much longer. Police officers take much longer, or may not even respond to a 911 call because of being short-staffed. Fire are also being delayed. And then our emergency departments are extremely stressed. So what do we learn? What's new? What do we need in our family plan, and how do we need to protect our families? These are those really critical elements, and we've covered this in an entire webinar. But what I'd like to do is just to address, what is the state of our safety net? And Bill and I and Dr. Boats have been using the metaphor of us performing over a safety net. Unfortunately, there are big holes in it now because of COVID, but it also doesn't cover a lot of the emerging threats. So what did we learn? Our public safety net is stretched with many gaps. What's new? Bystander rescue care could not be more important. What do we need in our family plan? The family needs to be ready for new threats and risks. And how do we protect our families now? Prepare for delays, just as I described. So I'd like to have Chief, and frequently I call Bill doctor because he's as smart as any doctor I've met, and he is really, really a wonderful leader and pathfinder in threat safety science. Bill, can you address for us this safety net? And I'll stop sharing so they have a chance to see you as you speak.
Well, thank you very much, Dr. Denham, and it's an honor to be here with everybody today to discuss the pandemic and the 1,000 person study. you mentioned the safety net, and you saw all the components of the safety net. And I personally have come to the conclusion that bystander care is probably the most important thing that we can all do, that we have control over, that will help us and help our families more than anything else. The safety net is not only stretched, but obviously it has holes. And so when you think about this whole issue of what the pandemic has brought to our country, as well as what was preceded by a lot of social unrest, and then you take a look at what's going on in our communities today with the economy, the inflation, and other factors. We are in a global economy, and so you talk about population kinetics. People are now working from home more than they are in the offices, so the populations have shifted around. So now you're seeing a change in the opportunities for types of criminal acts. So now you're seeing criminals that are changing what they do. For example, across the United States, you're seeing a vast increase in the theft of catalytic converters. Obviously, that's for the cost of the precious metals, which you're not able to mine because of people that have been sick in the pandemic. A tremendous amount of things. It's also gang members and very violent criminals that switch to that because it's more lucrative. And now when you have a confrontation, it's more violent and people are dying. And we've seen that. We've seen police officers shot and killed over that. So that's just one of the things. Traffic deaths, because there's not a lot of contacts, not a lot of work with the police. Traffic deaths are at an all-time high. Murders across the United States, according to the FBI director that spoke just a few days ago, is at a 60-year high. So violent crime is way up. Traffic deaths are way up. You're seeing the types of crimes changing around. Domestic violence is way up because a lot of the victims are no longer be able to get respite by going into the office and getting away from the abuser. And so there's a lot of changes that are going on, and what's caused the problem is that you can't get that treatment that you need. You need that bystander care. Ambulances now are delayed at the emergency rooms that are packed, they're overwhelmed. So now you don't have an ambulance available to go out to an emergency, as we have more and more people that are sick. A lot of people are delaying their medical care. So now you're seeing other types of illnesses come to bear, and more emergencies that are out there. It's just terrible. So we even have the problem in our supply chain. When we try to buy new emergency vehicles, there are no vehicles available. The manufacturing is way behind. There's issues with supply across the globe. We're even told that there's huge delays, 6 months or a year to get replacement vehicles. On top of that, we're having what we call buy board. The state and government has a buying through a what they call a buy board. They don't even want to sell to the local governments anymore. They don't want to sell because they can sell those vehicles if they come in to a much higher price to an individual than they can to the state and local governments. So we're out of whack. So it's stretched that safety net. It has created holes in the safety net. And personally, I stress that with bystander care, it's the most important thing you do. Now, bystander care is pretty comprehensive because it does talk about what should you do. What is your safety plan? What do you do at your home? What do you do if somebody does become sick and infected? How do you separate them? How do you quarantine them? If you have to take them to the emergency room yourself, how do you do that? And what information should you have? And what are going to be the limitations when you get there so that you can participate in that medical care of your loved one? So there's this whole spectrum out there that bystander care covers. Each and every one of these webinars have covered portions of that. It's available to each and every one of you. Anyone is available at no cost. So again, that safety net is in pretty tough shape right now. And we're asking everybody in our communities to realize that and to come together and help each other. So back to you,
Bill. Thank you, Bill. And one of the most surprising things is that the leading cause of death of young people now has moved from motor vehicle accidents, which has been for 60 years, to gunshot wounds.
That's correct.
And which really kind of talks about the uptick in crime that you've addressed in the safety net, but how critical it is because somebody can bleed out in 3 to 5 minutes. And so that's why bystander care is so important. Well, listen, thank you, Bill. We'll come back to our slides, and we're delighted to have Heather Foster with us. We'll be addressing the issue of our critical, what to do when we are at home. And she was just a wonderful leader of that. And I'm going to make sure to properly share the slides here. And And for those of you that have come on late, I'm sharing these from a beach in Southern California, where I've had the opportunity to participate in a University of California Irvine wilderness emergency competition and watching it and taking pictures, and it's just been awesome. So let's talk about a number of the programs that we had. One of our first webinars was Coming Home Safely, Hot Zone, Warm Zone, Safe Zone. What did we learn? What's new? What do we need to do in our family? And we identified that the hot zone was at work, the warm zone was transportation and getting to and from, and our safe zone we had to maintain at home. So what did we learn? Aerosol spread is now the critical issue. We didn't know that at the beginning, so we all emphasized cleaning and washing and gloves and etc. But now we know that vaccination, ventilation, masking have enormous impact. Home testing is not being reported now and can't be an early warning sign in your community. So as we look at the balance of community immunity and infection rates, we've got to look at other numbers. What do we need to do in our family plan? Protect your vulnerable members from aerosol spread. Much more important to think about when we're telling the kids, don't dare share air. How do we protect our families? Continuously monitor your community risk, wastewater, hospitalizations and deaths. Testing data is now weak. So as we look at how we kept, our second webinar was how we keep our kids safe and how we can move from the outside and inside threats that put us at risk to a reduction in that for family safety. Dr. Brittany Owens couldn't be with us today, but continues to underscore the critical importance of vaccination and the basic behavioral principles that we need to follow, and also to make sure to get your kids into the emergency department when necessary, not being afraid of getting the disease, and make sure to get the rest of those vaccinations. The framework that we've used is for a given threat, we have a vulnerability. So our given threat times our vulnerability, our weaknesses to be exploited by the threats, equals the threat to our family, the probability of harm. And so our focus was on inside and outside threats and building resilience. And what's happened, as Bill said, staffing shortages in law enforcement, emergency departments, and healthcare have increased the outside threats. And so as we look at this, we really need to focus on this. Now, so what did we learn? Every family needs to have, it has a unique risk profile. You need to look at your family. You're not going to be like the Joneses next door. What's new? There's a huge payoff to protect your vulnerable members. Now we know that our seniors, our immunocompromised, our children. What do we need in our plan? Protect those vulnerable members and be thoughtful about them. One shoe does not fit all. How do we protect our families now? Continuously monitor the risk, community immunity versus infections, and know what to do if you're infected. Providing care at home, and Heather, this one was one that you just helped us so much on. Providing care at home. What Heather and Dr. Boats and doctors at Mayo and UCI and UCSF and our wonderful group of clinical leaders helped us do was put together a care room checklist, setup checklist, supplies checklist, and home care checklist. We did this early in the pandemic when we thought that contact surfaces were much more important than they are now. So what did we learn? We don't need to obsess on contact surfaces. That doesn't mean we neglect them. We need to do proper cleaning. But what's new was the aerosol spread, and that isolation really did work and does work. What do we need in our family plan? Emphasize ventilation and family and family masking. How do we protect our families now? Be ready for isolation and quarantine. The CDC guidelines are updated, and testing can really impact them. So Heather, would you like to share with us your thoughts of where we are now 25 months after the beginning of this program?
Can you repeat the question there?
Yes, Heather, thanks for being on. We know you were up all night taking care of patients. God bless you for being on today. You did such a terrific job, Heather, helping us put together our program and checklist for caring for people at home. And now we're 24, 25, 26 months after we got started. What updates, what lessons learned have we still really need to be careful about someone at home and taking care of them. What would you like to add now that we're, from what we've learned over the months?
Well, sure, Chuck. I think a big thing that we've learned through all this is that we definitely are are capable of taking care of patients in the home, provided we follow those guidelines, right? We've proven that that's definitely doable, even for the lay person. Again, I think the push for vaccine has never been greater. And now that's been FDA approved on many levels, especially for our kids, I think it's making it definitely more manageable, not only at home, but also in the inpatient setting.
Fantastic. Thank you so much for all of the work that you did. And you were a nurse infection preventionist at the time when we were building it, and just counseling the families on their worries. And would you agree that we have to still keep vigilant? I think we've got waning vaccination protection. At the same time, we've all got COVID fatigue, but we've also got some variants that are popping up. And your advice to other moms and dads?
Yeah, I think we just got to, we still have masks, and I think they've been proven effective. We still have vulnerable patients, and quite frankly, Chuck, I think we've seen people in the community that have voiced here that they're going to continue to be vigilant because they are prone. We've actually had quite a few people sick, and not with COVID, because I think people are they're kind of reverting back to their old ways. Flu's definitely very much alive and well. And I think if we can incorporate these practices that we've used and learned with COVID, we can avoid those illnesses too.
Well, thank you. We really appreciate the great work you've done. And on behalf of all of us, our thanks to the nurses and the great care that you've delivered.
You're welcome.
As we move to now emergency rescue skills, what did we learn? What's new? And what do we need in our family plans? This is a really important area. And so I'm going to abbreviate our formal presentation of the slides and make sure that we play a full program on the 5 rights of emergency care with Dr. Toff Peabody, Dr. Christopher Peabody. He's an emergency medicine doctor. He's the director of the UCSF Acute Care Innovation Center, and worked with me when I developed the 5 rights of emergency care. And he will address these and put it in the context of today. The right provider, making sure we go to the right provider. And if we've got something serious, we don't go to the local urgent care center, we go to the bigger hospital or those who have our records. The right diagnosis, which means having those medical records and hanging on to them and being able to make them available. The right treatment is critically important. But the right discharge he'll address is vital, and having the right discharge precautions to know when to come back, and then continuity of care in the community. And we had Dr. Casey Clements from the Mayo Clinic speak on this. I just was 10 minutes before we started, I was with Dr. Chris Fox, right here on in the Southern California coastline. He's the chairman of the emergency medicine department that is hosting the wilderness care competition that I'm at right now. And they will all tell you that the emergency care loop is so critical, probably more important than it's ever been before, that we need to really recognize protecting ourselves if we take someone who's sick to the hospital, and then bringing them home. And most people didn't realize that Uber didn't want to take people that were COVID positive, nor the hospitals to bring them home. So what did we learn? Our safety net is definitely stretched. Preparation works. What's new? During the surges, emergency care was dramatically impacted and delayed. What do we need in our family plan? Follow our program for COVID or any emergency, the 5 rights of emergency care that we address, and then Dr. Boats will address the 5 R's at the end of this program. How do we protect our families? Readiness for any emergency, and this isn't just COVID. This is in case of an accident or anything else that might be an emergency, as you heard from Chief Adcox. What do we do? They're in the ICU. Dr. Boats covered a terrific program. I'm not going to belabor it today. Fortunately, we can have more people in the hospital than before, but still we're limited. Many are still maintaining the mask wearing, and it's critical to kind of understand that even though people that are not getting as sick, we still have many people in ICU. many that are on respirators, and even those that are on ECMO, the artificial heart-lung machines that reoxygenate the blood. And you can see those in our video, the video that we have prepared. What did we learn? We learned that our critical care processes dramatically improved. What's new? Laying patients on their abdomen in the hospital, called proning, allowed better oxygen exchange. Medications have had a great impact. But what do we need for our family plan? Be ready for new surges and what to do if loved ones get very ill. People are still getting severely ill, still ending up in the ICU, and many are still dying. We will very soon break the 1 million mark, and we're 60th or worse in the world on how well we've taken care of this disease. So have we been good at it? No, probably not. We're 4% of the world's population with 25% of the deaths. How do we protect our families? Understand what will happen in the ICU. Now, I'm not going to go into all the detail regarding the vaccines, but we went over the 24 months, Alpha, Beta, Delta, and Omicron, and this evolving nature of the variants, which may continue, and we now have Omicron. We now have Omicron variants that are even 25% more transmissible than the last, which was 50% more transmissible than Delta. So we know that this is still spreading, and you could see the heat map at the beginning of our presentation that it's a pretty big hotspot where I live right here in Southern California. We also learned that there's a movable middle. There's still a group that we really need to tackle who might have even gotten their first vaccine or their second, but are not up to date. And we know that the vaccine impact of the protection is waning. We're collaborating with and just actually helping distribute. We're not involved in pre-production, production, or post-production, but a terrific series of videos that are absolutely wonderful for teens and young adults that have been developed, and you can go on our website and watch them. There are versions that are adult focused, some focused for teens. They're in Spanish, and they're absolutely terrific to tackle this hesitancy issue. So what did we learn? Vaccinations are really safe and a first line of defense. Vaccination wanes. Those with vaccinations get infected, and those who are infected need it too. What do we need in our plan? Schedule the vaccinations. My wife today is getting her booster. I got my booster about two weeks ago, my fourth boost. My fourth shot. I got the first two, got my boost, and got my second boost. Why? Because protection is waning. How do we protect our families? Many forget to get the boosters. Make sure everyone is what we would call up to date. Vaccinated doesn't mean up to date. What about long haulers? Absolutely critical. The long haul disease is a time bomb. We're seeing more and more cases. I personally have 6 friends who I'm helping guide through healthcare who are having terrible experiences of fatigue or breathing problems, depression, anxiety, chest issues, inflammation of the heart. Even we've seen some that have had blood clots, and it's absolutely critical. So what did we learn? Long COVID is real. It's a time bomb. Even those with mild infections can get it. You do not want to get COVID because you don't want to be the subset to get long COVID. And even if you get a mild case and you think, oh, this is nothing like the flu, in 6 months, you could have a cardiac problem or a pulmonary problem. I've got friends that had mild disease and now can hardly get out of bed. Be vigilant and make the family aware that they can get it. Fight COVID prevention fatigue. We've all got it. It's hard to even contemplate us doing this webinar for you, but we know we have to do it. We're all fatigued. Make sure the family uses masks, avoids closed spaces, and keeps safe. We covered 10 best practices for reopening. We also covered the 4 Ps, which are prevention, preparedness, protection, and performance improvement. Chief Adcox helped us understand the concept of getting left of boom, which was a military expression of moving up the chain from IED damage that occurred to our great soldiers and moving up to where the bomb makers were to be able to stop them. It doesn't pay to say, oh, I'll wait till we have an explosion and then we'll have armor. What they said was, let's move up the chain and stop them from making the bombs. In the same way, we've got to do that with COVID. And we focused on the 4 Ps: prevention, preparedness, protection, and performance improvement. This is the model that Chief Adcox and Dr. Boats and our team are using to study threat safety science. We won't belabor it. It's a great webinar. We put together an essential worker toolbox to address the critical issues. But today we will talk about special care for special populations. What did we learn about those that are immunocompromised, seniors, and our children? We know that certain people are very vulnerable to COVID. We don't know why some are and some aren't, but cancer patients and transplant patients are very vulnerable. So you may be somebody who says, look, I don't care, I don't want to wear a mask because I don't care if I get COVID, but you may spread COVID to someone who's vulnerable, and really wearing a mask is really, I believe, the patriotic thing to do. Wearing a mask to protect the other folks in your communities, and it's a community service thing, whether you get COVID or not. Prevention behaviors really do work. That's what's new. We know now aerosol, masks, ventilation critically impact things. What do our families need to do? We really need to customize our family plan. You may have a family that has nobody who's vulnerable. I've got a family with 3 members of my family that are very vulnerable. We behave differently. We don't go to restaurants right now and eat indoors. We just pick restaurants that are outdoors. Then we don't worry about it. We have friends over. Do we have them indoors? No, we have them outdoors. We are customizing our approach depending on who we're with. How do we protect our families? We've got to fight COVID prevention fatigue. The variants are still present, and the communities have let their guards down, and it's a real challenge. Now, I just had the wonderful opportunity of spending time with Dr. Robert Katzer. Dr. Katzer is one of the emergency medicine doctors who helped Charlie Denham, my son, and David Besch by helping us teach our MedTech program here on the West Coast. He's actually the lead of the Wilderness Emergency Medicine program that's right behind me. They're getting ready to have a break, and they will identify who the top leaders are. And Dr. Katzer helped us understand travel. David Besch and my son Charlie put together a checklist. Now, Dr. Katzer advised us from the emergency medicine standpoint, as did Dr. Clements and Dr. Fox, but it was actually David Besch, an award-winning teacher, and these youngsters who, back when we started MedTech in 2015, who helped develop a checklist for the family lifeguard. What was it? It was a way for us to protect ourselves when we have events. Now, we may be through the woods on Omicron. Maybe Omicron BA2 and 2.22 and whatever we move on to may not be a problem, and COVID may be something of the past. Let's hope it is. But there are other pandemics that are coming our way. We know that for sure. And being able to have an event and practice what we do before an event, during, and after an event, it was our focus. And so what Mr. Besch and Charlie did was put together a set of checklist items. And what they did was, over the last 2 years, modified it. We didn't know about rapid antigen testing and identifying whether people were vaccinated or vulnerable and at risk, as you see in the middle checklist at the very beginning. So this checklist has evolved. And so what did we learn? Aerosol spread, again, much more important than contact surfaces. So spend less time wearing gloves and washing up before and after an event, although we want to wash and we want to be careful, but we really want to be careful about don't dare share air, keep our bathrooms ventilated, and make sure to wear masks if we're indoors. We don't know whether our guests are vaccinated or not. If we know, that's a help. If everybody gets a rapid antigen test, we don't wear masks. We're outside and we don't worry about it. What's new? The huge payoff to attention to vaccination of guests, using the rapid testing, avoiding indoor and poor ventilation. And what do we need in our family plan? Build in that aerosol precautions. And Dr. Katzer, and I won't go into the detail, but we had a whole session on travel and what to do on the whole loop of travel, air travel, train travel, car travel. Bystander rescue care. Chief Adcox and I and Dr. Boats have been working diligently on these 8 target areas. And what we learned with bystander rescue care is that Good Samaritan care can be safe, even though people have COVID. Emergency response services are stretched more than ever. We could deliberately practice to take care of people, use, for instance, HEPA filters. We could do CPR and use an AED, wear gloves and masks and take care of people. We should never avoid being a good Samaritan if we use the proper personal protective equipment. You'll hear from Dr. Cox in a recent video that we have that he has taken care of patients for 2 years. He's been intubating patients. He's been in poorly ventilated areas, but he wore an N95 mask. He was very careful with hand washing, never got COVID. And then testing to navigate care was another topic. And I highly recommend you watch the whole program. We re-reviewed it. There's almost no new information. We're pretty up to date on that. We focused on both the antigen tests and when we use a rapid antigen test and when a PCR test is indicated and how that relates to the viral load. I won't go into the detail, but I will tell you that it really helps families understand the difference between the RT-PCR test, when to use it, when your doctor will use it, and the rapid antigen test. So what did we learn? Consumers have great confusion regarding testing. Watch the full video. I think it'll really be worth it. We spent 2 to 3 weeks developing it, and it's still up to date. Home antigen tests tell us whether we're contagious. PCR tests can be positive after you're contagious. What do we need in our family plan to make sure everyone understands the basics of testing? And what can we do to protect our families? Have home rapid antigen tests ready for the next surge. Pay attention to the CDC. Do the test work maybe with the next variant or not work, and we can use those tests to allow us to really do the kind of work that we want to have done to protect our families. Our folks that have been with us today live are Chief Adcox and Heather Foster. We're going to show some video clips of that Dr. Boats is reviewing the 5 R's, and especially Dr. Peabody addressing the 5 rights of emergency care. I have poor battery life on my computer here, and I'll have Kyle Kemp play those videos. But what I wanted to do is to have you remember all of our teams. We say fight the good fight, finish the race, and keep the faith. Everyone is a patient and everyone can be a caregiver. And I'm going to stop sharing for a moment here and just want to see if Chief Adcox, are you still with us? If so, do you have any concluding comments that you'd like to make? And Heather, before we move on to the videos, and we'll play and what we'll do is we'll play Jenny Dingman's close, and then we'll play these longer tapes for those that want to watch the extended session. Go ahead, Chief.
Thank you. No, the only closing thoughts I have is to ask everybody to please avail themselves to all the information, go through there, pick out what they need, and to develop their safety plans and to get all their family trained as bystander rescue people so that they can do what they need to do, and just help one another in the community. Keep your eyes open, and we'll be safe and we'll get through all of this. But we're in one of the most trying times in our lifetime. So,
thank you, Chief, and thank you for being such a terrific pathfinder in threat safety science and working on the final papers that we'll publish of our 1,000 family hospital study. It looks like it's going to be a series of papers, may even be a book, because we've had a lot of work that I think that will contribute to future epidemics and pandemics, and we've certainly learned how our public health systems have failed and how we failed to take care of our families. So there's a lot that we can do. Heather, are there any final comments that you'd like to make before we move to Jenny Dingman and then play the sessions from on the 5 rights of emergency care and the 5 R's?
Just that I'm so grateful, Chuck, that we had this platform to work from to help others. And then again, just encourage many people to continue to be vigilant in this fight against COVID.
Well, thank you. Thank you on behalf of us for all the caregivers at the front line that have done a great job. We know that workplace violence is just off the charts, and a lot of people are very frustrated, and they take it out on their caregivers. And we're so blessed to have you hanging in there for us. So thank you so much. So what I'd like to do is have Kyle Kemp now play. Kyle, would you please play Jennifer Dingman's closing thoughts? Then we'll move to Dr. Peabody's 5 rights of emergency care. And from that, we'll move to Dr. Boats addressing the 5 R's of the safety plan for those that are unfamiliar with them. And thank you very much. I know my battery life will die. We did this as a prevention so that I'd be able to continue to serve here out remotely. Thank you so much.
Jenny, would you please share with us your last word, the voice of the patient?
Thank you, Dr. Denham. This study has just been so enlightening for me, and the results of this study will help all of us with our families and the people that we love proceed in the new normal. We don't necessarily know what the new normal is going to be, but at least now we have a roadmap, thanks to groups like this one. Again, I want to thank everyone for being here today, and everyone who's listening in. Please share this information widely with your colleagues, and looking forward to future webinars. God bless everyone.
Thank you, Jenny.
Care University serves patients, family caregivers, and professional caregivers with education targeting care issues with expertise from a network of more than 500 subject matter experts from leading medical centers. And we will measure our success by how we will protect and enrich the lives of the families we serve, both those of patients and professional caregivers, because everyone is a patient and everyone can be a caregiver. At CareU, our challenge is to target what we call high-impact care hazards, those conditions that are the most frequent, severe, preventable, and measurable. Our solution is to help patients, families, and professional caregivers adopt new behaviors that can become life-saving habits, which we call lifeline behaviors. Few families have been spared from the fear and stress of a healthcare emergency.
Trauma team to emergency.
Our emergency department visit was a blur. It's so frightening to have someone you love in trouble. Normally I can deal with stressful events, but I was just paralyzed. Without a guide and a checklist to follow, we would have been lost.
Whether you or a loved one receive acute care for an emergency, chronic care over time, or even preventive care to stay free of disease, there are many things you can do to make your journey safer and better. There are very specific actions you can take, especially during an emergency when stress can blind even the most competent of us. This module addresses a framework we use to help you get the best emergency care possible. This framework is called the 5 Rights of Emergency Care. We created a simple checklist you can use with a paper and pen that applies to what you learn. Or download it and use it on a computer, or even use it as an application on your smartphone. Your caregiver may even provide it during an office or emergency room visit. So let's review what you'll learn about the 5 Rights of Emergency Care. The framework has 5 main sets of right lifeline behaviors or rights that you can follow to get the best emergency care for you or your loved one. The right provider. If you have an emergency in your own area, it is important to know where the emergency care providers are, and if you have time to make a choice, make the best choice. Most people think of going to the nearest hospital. However, that may not be the best choice for you or your family. Emergency services vary from urgent care centers, many of which are like a 24-hour doctor's office that provides certain but not all emergency services, to specialty emergency departments at hospitals that specialize in trauma, stroke, cancer, and pediatric emergencies that strike children. What is critical to know is that your prior medical records are vital to your care, and without access to them, tests may need to be repeated to get the right information. This can cause great delays when time is of critical importance. So one factor, if you have a choice, is to go to the emergency department at a hospital where you've already been treated that has access to your medical records. For instance, you might drive right by an urgent care center and go a little farther to the hospital where you've been treated before. This will save you significant time and money and may even save your life. Many times emergencies like car accidents, falls, strokes, or heart attacks strike with little warning. And that is why your ICE, ICE, or your in case of emergency contact information should be in your wallet and on your smartphone. We will show you how you can put this vital information on your phone because first responders are taught to check there first. You need to have more than one contact since you might be with the family member you choose during an accident. The right diagnosis. Bring your medical records if you have time to get them together, a full set of them if you have them. Anyone with a serious disease should have a set accessible at all times. Secondly, bring all your medications, including the over-the-counter medicines you regularly use, in a bag so that the doctor can see them. This should include vitamins and dietary supplements. If you have a medication list you follow, bring that too. For many emergency conditions, your blood will be drawn and prior records are important for comparison. Always find out why you're getting such a test and what will be done with the results. Finally, x-rays and other imaging tests may be run, such as ultrasound studies. And again, prior studies or at least prior reports of imaging may be helpful. Sophisticated imaging studies such as CAT scans or magnetic resonance imaging studies, MRIs, may be done. Make sure to know why and ask how you can get those studies on compact discs for the future so that you can leave with them. If you ask the imaging technologist when they are done, it can really save time. If you or your loved one are too sick to ask, any family member can do the asking, always graciously. The staff are your best friend. The right treatment. Shared decision-making is a way of working with patients and families that our best caregivers are trying to do. This means they are involving you and your preferences in the care that you or your loved one receive. So don't be afraid to ask questions and understand what the emergency department team are recommending for your care. The plan for your care might involve treatment to address short-term symptoms as well as long-term care recommendations. For instance, you might come in with a cut that needs to be sewn up or a procedure, and during your visit, they find that you have high blood pressure that your primary care doctor will need to treat soon. There may also be additional things that they need to do after initial symptoms are treated. In a majority of ED visits, a prescription for medication will be written and over-the-counter medicines will also be recommended. You need to know what they are, why they're recommended, and when to start and stop taking them. 2/3 of patients in hospital beds come through the emergency department, so a hospital admission may be recommended for you or your loved one. Ask why the hospital admission is necessary and who will be the caregiver team they will hand you off to when you move to a hospital bed. Ask what's important about the care that you'll receive. A huge proportion of medical errors occur during such handoffs, and you and your family need to be a vital part of the communication chain. Frequently, patients sit in hospital beds awaiting care, and a knowledgeable and gracious family member can help keep things moving. Right discharge. This is one of the most important segments of the trip to the emergency department. Imagine your symptoms have been addressed and you think you're out of the woods and on your way home. This is where so much preventable suffering, cost, and worry can be addressed with the discharge plan. Return precautions are absolutely vital. This means what you need to know about returning to the emergency department. You need to understand your medical problem that was treated, the diagnosis, and what was determined through testing, the treatment you receive, and what you'll need to do or receive going forward, the vital return precautions, what you need to be watching for, like a rise in temperature or other things, such as no improvement or a return of symptoms. Simply put, any reason why you should return to the emergency department. Your care team will give you a list. Just like you reconcile your bank book, you must have a reconciled or updated medication list if medications have been changed. Make sure to know what to take and what not to take. Understand your care plan, what you need to do after you leave so you can get better, the wound care, diet, and special treatment needs that need to be addressed, what to do, who to see, and what you will need to do when you see them. And the one thing people fail to remember is to get all the paperwork. Try to get all the imaging reports and test results. They will save you an enormous amount of frustration and cost later on. And if you can get the imaging studies on CD, do so. These imaging studies are expensive, costly to duplicate, and vital in the future. Many organizations will give them to you on a compact disc. At the end of an emergency department visit is the best time to get your records. You'll have a terrible time trying to get them later. The right follow-up. This starts with the regular caregivers or the primary caregivers you need to see an update regarding your emergency department visit. Do not presume that they will get the records from the hospital or the emergency department without you. If you bring them on your follow-up visit, you know they will have them. Update your home records, both with the emergency department records and whatever your regular doctors do in follow-up. Keep hard copies, and if you can, keep digital ones. And finally, emergency department visits often stimulate the need to see new doctors, specialists, or even get second opinions. And there are right ways to get them and many wrong ways to get these visits. Patients and families can play an enormously important role in getting the test and emergency department records to all of your doctors to get the best follow-up care possible. So now that you've been introduced to the 5 rights of emergency care framework, you can see how learning about new lifeline behaviors can really have impact. Other Care U modules will help you along the way. Of special importance might be the 5 rights to your medical records and the trip to see a specialist, how to get a second opinion, and others. There is so much you can do by being engaged and working with your professional caregivers. God bless you on your journey. So, Top, thank you so much for taking time to help enhance and build on the concept of the 5 rights of emergency care. Now that we're in a very intense time and we know about a lot of the COVID-related issues, what are you seeing now that we need to be aware of as patient safety leaders regarding delayed diagnosis, misdiagnosis? What are the things you're seeing that we really need to be aware of?
Well, there's a number of things, Chuck. I think it all stems from kind of communication. And the communication really has to do with the caregivers that join patients, especially in the emergency department. And what we're seeing is that the patients aren't allowed to have their caregiver present. A lot of times the triage nurse gets the information as best they can, and then the patient's caregivers is dismissed, and the patient comes back to the emergency department unaccompanied. And so a lot of times this information is transferred, critical information is transferred from the caregiver to the care team over the phone, and sometimes that's delayed. Sometimes we don't have the right medication list, so medication reconciliation is a big deal at the moment. We see patients that are reluctant to come to the emergency department and have, in certain cases, seen kind of delays in care. We've also seen that the effects of telemedicine is for primary care, and in particular, a couple of cases where in prenatal care where blood pressures weren't able to be taken in the 3rd trimester because the visits were switched to video visits, and we didn't have accurate blood pressures on very critical patients. So we've seen some critical cases kind of fall through the cracks because of issues related to our national emergency.
How about adverse drug events? What are you seeing a change in the kinds of adverse drug events that you would typically have seen previously and what you see today?
I always want someone at the bedside with the patient that knows them better than I do. And what I'm finding is that the caregiver that is normally with the patient day in and day out, whether that be their spouse, that be a caregiver that goes into the house daily to work with our elderly patients, aren't allowed at the bedside anymore. So yes, we are seeing a lot of issues, especially in relation to medication reconciliation. Most of these cases are near misses. Most of them are, but as we know, the near misses in patient safety is the siren right before a major event. And so I personally haven't seen a major event yet in relation to medications, but I've seen a lot of near misses.
How about adherence and compliance to the use of the medicines now that there's a protracted time period between them seeing primary care or a specialist? Do you see people dropping off of their meds and not taking their anti-coag or not taking their blood pressure medicines or not taking critical medicines that are keeping them healthy?
I have seen a number of cases where patients have waited for refills because they have to go in to or have a telemedicine visit to be able to do that. So I've had a couple of patients who came in at the end of their when their medications have run out and they haven't been able to take them for a few days to get prescriptions, and this is in the emergency department. So I'm sure our primary care colleagues are seeing a lot of this right now. Um, I've also seen a number of patients not have their medications, especially blood pressure medications, adjusted as frequently as they may in the pre-COVID times because we haven't been able to get accurate blood pressures. Again, in the kind of telemedicine world that we're living in.
Do you think there's a place for a virtual med reconciliation so that people don't have to go in, but we are looping back and just reconciling the meds and making sure everything's as planned and everybody's in agreement?
Well, absolutely. And I actually am a huge proponent of telemedicine and think that the access that it provides for patients is crucial in these times and also moving forward. I think it's here to stay. I just think that there's certain aspects of it that need to be ironed out. One of those that I've seen, and I'll mention it again, is kind of accurate blood pressures. How are we going to do that in the era of telemedicine? Is a home blood pressure cuff enough, and do patients that have limited access to healthcare have access to those devices? So yes, I think a virtual medication reconciliation is kind of in the pipeline, is probably being used in certain systems. I do worry about kind of that digital divide for patients that have lower access to healthcare in general. But I think, yes, we are seeing this being very much accelerated because of COVID.
So, do you recommend that every family should have a pulse oximeter? We've seen that a lot of people are starting to recommend not having that in addition to recognizing the CDC's emergency signs, which they've now got posted on their website, that they relate to oxygen saturation. Would you recommend families that can afford it to get a pulse oximeter?
Well, especially families that are COVID positive, I think having a pulse oximeter is a really good idea. Should every family have a pulse oximeter hanging around? I'll tell you, our family does, but I'm also an emergency physician and like to have that data around. But I don't think it needs to be a standard kind of family thing unless you have one of those diagnoses, especially COVID being one of those diagnoses. I think having a pulse oximeter is key to kind of the way we've been seeing the disease progress when you're at home. And so, yes, a pulse oximeter in certain circumstances is vital for care at home.
How about having your medical records on a thumb drive and being able to come in with that? Are you all able in the emergency department to be able to access a thumb drive, or are there security issues that make it hard to do that?
Yeah, you know what, Chuck? I think having your medical records and at least your medications kind of on your mobile device and being able to show that directly to the clinician and to your care team, so that they can input it into their system, is actually perfectly fine and probably easier for patients to have because it's something they have on them all the time. So I've been finding that very helpful. To date, I haven't ever had a patient come in with a thumb drive that I've been able to access. So I think but the phone records, that happens all the time. So is that a patient portal that your healthcare system already has that you can show your the paramedics that come or the emergency providers once you get to the emergency department? That would be great. But if you don't have access to one of those portals that has your up-to-date information, keeping a list of your medical diagnoses and keeping a list, especially of your medications, including the dosing, is critical for the care team in the emergency department.
Fantastic. So really, we can put on our phones, we can put files and learn how to put files on our phones that can be opened up. Do you recommend having family members email records directly to the emergency department? Is that allowable in terms of HIPAA these days if we can't get things to you directly?
Again, I think most of the emergency care information is done kind of in a face-to-face manner. And so I think showing them the document on your phone itself is perfectly acceptable. Again, haven't had a patient email me because I worry about the security of
Sure.
kind of that transfer in relation to HIPAA. There are ways to send secure emails. There are ways to kind of, especially in certain healthcare systems, send secure emails to your providers. However, in the emergency department, it's usually a fast-paced environment. I would much rather just have you show me the information you have on your screen.
Fantastic. Coming back to medications and adverse drug events, we know the top three are anticoagulation, opioids, and diabetic agents. Are you seeing things later and you are seeing compounding problems with them? They're over 60% of our adverse drug events.
So it's interesting, especially, so I work in the Bay Area in San Francisco, and we've been seeing a lot more fentanyl overdoses kind of hitting the levels of what we were seeing back east before COVID. We've been also seeing a lot of anxiety and depression in relation to, I think, the lockdowns that have been happening and the social distancing and not being able to kind of interact with people. So we've been seeing a lot of kind of isolation and folks self-medicating because of this, and so we've seen a lot of exacerbations of depression. We've seen more suicide attempts than we have in the past, and I've seen more fentanyl overdoses lately. And I'm not sure if that's necessarily related to COVID, but I will say that it's probably related to the access of this medications coming into our region.
How about anticoagulation and related to and not related to COVID? Are you seeing any changes that
I think mostly the things around anti-coag that I've been seeing is getting access to your prescriptions, especially folks that are having that take anticoagulation for a valve replacement. Most of these patients are still on warfarin or on Coumadin. And they haven't been able to access the Coumadin clinic as much as they had in the past. So we have been seeing some super therapeutic kind of warfarin levels come through the emergency department. We've been seeing basically the same amount of kind of head injuries and those things in relation to the NOACs, the novel anticoagulation agents. But as far as the errors that are around in anticoagulation are still present as they were before COVID. So we haven't seen really much change.
So what about diabetic agents in diabetics?
So we've been seeing a lot. I mean, I can't imagine how difficult and challenging it must be to kind of have your practice completely changed as a primary care physician. So I'm going to assume that there's been a number of changes within the management of diabetes, especially with, you may even have better access to health coaching now with telemedicine. But getting access to kind of patient records and getting glucose checks in the clinic, obviously patients don't have those type of access. In the emergency department, I basically have seen no significant change. I see diabetes out of control before COVID, and I've seen diabetes out of control after COVID. So so we still see a lot of diabetic-related complications coming through the emergency department. Perhaps some of them coming in a little later than they would have otherwise, but I've seen no real significant change there on the medication front.
And how about with children? Are you seeing delayed diagnosis of appendicitis, asthma, and the various things that you're seeing in kids? Are you seeing a change in what families are doing with their kids?
Well, it's interesting. So we're going into flu season now. I've seen a significant decrease in the amount of kids that have been coming to the emergency department, and perhaps that's because of social distancing. Children aren't getting the amount of URIs that's triggering asthma exacerbations or something like that. I think maybe early on in the pandemic we saw exacerbations of asthma that waited a little too long. But I would say that now that the community is kind of opening back up and that people are trusting the kind of procedures that we have in the emergency department to keep people safe, I haven't seen that significant amount of delayed diagnosis in children, but I have seen the volume of children coming through the emergency department still being decreased.
Dr. Peabody, you've done a fabulous job helping me articulate the 5 rights of emergency care. Can you apply the 5 rights as they pertain to children and teens?
Absolutely. So I think with the COVID-19, knowing the 5 rights when you want to come to the emergency department is as important as it was beforehand. There are a few things that you should know about coming to the emergency department that is different in the COVID era. The first one is to know that if you need to come to the emergency department, please do. We want to see you and your loved one in the emergency department should they have a needed emergency.
So what about the right provider?
Chuck, the right provider for emergency care is crucial. You want to go to a place that has your records, knows your general history, or has contact with your primary care system. That was true before the pandemic and is true right now during COVID-19. You want to go to the emergency department that knows you. If that's not possible, go to the closest place that you can if it's a true emergency. And if it's an emergency where you have to call an ambulance, be aware that the ambulance will make those decisions for you and usually chooses the exact right place for the critical moment that you're facing.
So what about the right diagnosis as it applies to children and teens?
I think especially when it comes to teens and young adults, Chuck, is that they may have never been to the emergency department by themselves. And during COVID-19, it may be the first time that they go to the emergency department. And so just knowing that you should have your medical information, the medications that you're taking, any workup or lab results that are recent, any imaging that may that you and your family may have is going to be really important to have on hand for that physician and care team that see you at one point in time in the emergency department. So I think this really pertains to teens that are just kind of learning what an emergency visit is like.
So as we talk about the right diagnosis and we think about children and teens and maybe only one parent there, communication is going to be pretty vital, isn't it, as you think about the right treatment?
Absolutely. So communication is always key in closing the loop is with your care team, knowing exactly what's going on. What I've found with COVID-19, and especially with parents that may not be able to be with their loved one, whether it be a teen that's coming alone, or if most places are only allowing one parent to come with their child. So we're using whatever means possible it is to close the loop with parents. And if that includes electronic media like FaceTime or text messaging, we'll do that.
So you've made a great point in the 5 rights about the right discharge and return precautions. What's important as we think about these younger kids and young adults and teens?
Emergency physicians and their care teams only see you at one point of time. And sometimes during that point of time, the right diagnosis may not have been come to. So you really want to know when to come back to the emergency department if things change. And so getting the right discharge instructions, closing that loop with your care team, going out and going home, it's actually one of the most crucial points of knowing what's going on in the emergency department. So the right discharge is probably out of the 5 rights, Chuck, I think that's the one where I would focus the majority of my time.
And then finally, the right follow-up, that continuity of care back with the pediatrician and making sure that the flow of information can occur. And I would expect in COVID, that's even more challenging.
Absolutely. As primary care visits have gone almost completely online, you want to be able to have your primary care access the information that was gained during that emergency department visit. And so knowing what that right follow-up is, asking the emergency physician and the emergency physician care or the emergency department care team while you're being discharged, hey, what should be my follow-up plan? And is there any information that's not going to be translated directly to my primary care team? And if there isn't, then come up with a plan on how to get that information back to your primary care group.
Fantastic, Toph. You're always so helpful as we talk about emergency medicine and patient safety. This has been really helpful.
Thank you, Chuck. And if there's ever any other questions, I'm always happy to come back on.
Well, Dr. Boats, we started out with our survey and now have many more than 1,000 family responses to our survey addressing the 5 R's. We're now 24 months into this pandemic. And as you look at advising families of critical essential workers and the general public, let's cover the 5 R's. And so the first R is readiness. After 24 months, how should a family look at readiness?
Well, I would hope that a family would look at readiness the way we did from the very beginning, which is have a plan. Think about what your risks are, especially if you have family members who are in a high-risk population with immunocompromise or chronic medical problems. And use that information to formulate your plan and stay ready. You should constantly think about what are the risks in not only my community, but in the activities that I'm going to do now, especially since things are opening up and we're much more likely to be in contact with larger groups of people. We need to think about that in trying to maintain the safety of ourselves and our families.
The second R is response. We know a lot more about what to do if we have a family member who has a positive test. And many of us are getting notified frequently that our family members, our kids in school, are in contact with someone that has been confirmed to have the disease. Anything new that we should think about as we think about how to respond if a family member A gets sick or B is in contact with someone who has had the virus?
Well, I think that not only did we think about readiness, but now we're thinking about how to actually deploy our family safety plan if in fact someone becomes infected. It's the same strategies that we've talked about all along to try to reduce not only the risk to the person who has the coronavirus for their safety, but also the safety of those around them. I think that the strategy is still the same. I think having vaccination as part of the readiness plan has perhaps mitigated some of the concern for very severe illness that we might see in someone who comes down with a COVID viral infection. But nonetheless, the rest of those strategies in our family plan still remain true, and we should practice them.
Our third R is rescue. And we certainly know a lot more about what to do if we have a family member who is sick and needs to go to the emergency department. You and Dr. Peabody from UCSF, our wonderful teammate, and Dr. Chris Fox from UCI and his colleagues have really helped us understand the factors that are important as we try to rescue someone who might be getting sick. And now we've been around quite a few that have gotten sick and actually needed help getting to the hospital or even have long COVID and might need to go to the hospital. Any tips regarding 24 months after we have started to learn about this virus?
Well, I think the concept of rescue is important because we have to have a plan for how to go from home care, where we are providing the level of care necessary for someone who's infected with coronavirus, to now seeking healthcare in a hospital or a clinic. And I will tell you, perhaps the difference over the last 2 years is that it's not the chaotic pandemonium that it was before in an emergency room. And the healthcare system is learning how to work in a PPE-driven environment much better than we did initially. First, the supplies are better. People are used to using those strategies, and so it's more part of the fabric of how we practice. But it still can be challenging because of, the safety measures in place. Access to emergency departments can be limited simply because of those strategies they still have in place. Remember that people are going there also for other routine care, injuries, illnesses, all the reasons that people might go to an emergency room, prior to COVID are still in play. But now we have people who may need rescue because they aren't able to manage their illness at home and they seek additional care or a higher level of care. I think it's still the same challenge. It may not be to the same magnitude, but we have to take that into account when we're making our plan.
Our fourth R is recovery. And I don't know about you, but many of us have friends, family members, colleagues that are now suffering from long COVID. And I use the term time bomb. This is really, this is a time bomb in that it goes off after someone may have been sick. And I've got dear friends who are having a very difficult time getting back to any semblance of normal life. And it paradoxically, you and I've talked about the fact that when they try to exert themselves to get some exercise and get out and mobile, that it just knocks them back, and it's kind of 2 steps forward, 1 step back. Your advice to folks regarding what we know about long COVID, and I use it as a cautionary tale to say, people may be tired of COVID, but listen, you do not want to get long COVID. This is a terrible, terrible thing that happens to you.
Right. When we think about recovery, we're not only considering those people that have perhaps a normal recovery from a viral illness, which is how we hope COVID moves going forward, in that it's just one of the other viral syndromes that we have to deal with, and we aren't seeing the very critically ill response that people have, and certainly at risk for ending up in an ICU with life support and very significant end organ system dysfunction. But you're absolutely right. We need to think about long COVID, which is the circumstance where people who have been infected with COVID have long-standing, prolonged symptoms that can affect many of our organs. Notably, there's a lot of cognitive problems that can go along. We've heard about the brain fog. And people who have had long COVID are very limited in their ability to go back to work because they can't multitask. They can't remember things. They're afraid of making mistakes, especially if they're working in a high stakes environment like many of our essential workers are. They can have respiratory problems like a prolonged cough or difficulty with breathing or with sputum production and things like that that limit their ability to carry on their activities of daily living. There can be cardiac abnormalities that people see. Most notably would be just having a very high heart rate, a tachycardia, for no real reason. They're not exerting themselves very much, and suddenly their heart rate's going in the 120 to 140 range. There can be neuromuscular problems that can go on with problems with how well you can maintain your balance, or how well you can walk and ambulate without putting yourself at risk for falling. All of these things we've seen before in a number of different illnesses, but not so concentrated, I think, in a post-viral syndrome like we're seeing in many, many people. The real challenge is that the healthcare system is learning how to understand and manage long COVID while it's happening, and we're really playing catch up. There are a lot of people that are suffering, and we don't have a lot of answers yet because we don't have numbers that tell us whether the interventions that we're considering really make sense. We don't have the power to decide whether it's an effective intervention or not. And so we're learning as we go.
Thank you. And the fifth R is resilience. And I like to characterize resilience as a way of living going forward to reduce the potential risk of the threat, and use even the military term of target hardening, or the law enforcement term of target hardening. And for my family, I look forward and I say, what are the activities that we have over the next month
What's the ventilation of those buildings where there might be something held? Can we pick an outdoor venue? Can we pick an outdoor restaurant? Can we socialize or go to church services that are outside, and really reduce our vulnerability from the outside threat? Get everybody in the family vaccine up to date. Fully vaccinated, I think, is a term that's going to go away. I think up to date is perhaps another way we can look at it. And this idea of resilience, or hardening the target of your family to these outside threats, as well as the inside threats of vulnerabilities.
Well, I think you're right. I think resiliency is really an important dimension of our ongoing response to the COVID pandemic and any other illness or any other chronic medical problem that we face. I think that the idea of critically evaluating your activities moving forward to understand both the risks that it might pose to you and your family and the vulnerability that you might have at that particular time in you or your family is an important consideration. And you also have to think about the dimension of resiliency, which is, if something happens, how well do we respond and manage it so that we don't fall apart, so that we don't have a catastrophic event? How do we prepare and behave so that when we are faced with that, we follow our plan and we behave in a way that reduces perhaps the impact of that event and keeps us from falling apart?
And that, and that concludes today's webinar. Thank you for attending.